I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I am your host, Dr. Jordan Robertson. Today, we are going to dive in deep on the concept of insulin and the impact that this has on a woman's fertility. I've spent a lot of time looking at this topic. It's one that I have a personal interest in with respect to recurrent pregnancy loss and miscarriage. When I wrote Carrying to Term, I really dove deep on the kind of assessment strategies that we should be using in women to help predict the risk of miscarriage. This has really been sort of my passion project and mantra in studying miscarriages, that I really want to know which women are at risk before they have had multiple miscarriages. Just to circle back on that, in Canada and in the United States, women really don't qualify for being well assessed for their miscarriages until they've had 3. And after I had had my 3rd miscarriage, I realized that this was a big gap in care. I went back and looked at the literature, and we know in the literature that some miscarriages, not all, some miscarriages we should really see coming a mile away. These are the ones that are in women where they have an underlying risk factor related to their fertility, such as endometriosis or polycystic ovarian syndrome. These women perhaps need more heavy-handed support or more thorough investigation before they get pregnant in order for us to fully understand their miscarriage risk. And typically this isn't done, right? They're typically sort of clumped together with other miscarriages that are usually happening because of a chromosomal defect or that the pregnancy or embryo itself is not viable. We lump these women who have predisposed sort of risk factors for miscarriage in with the, I'm saying in air quotes, by chance miscarriages, and calling all of the miscarriages by chance, when after I had had 3, that really was not good enough for me. It wasn't good enough for me to say, that we don't check in with women or start doing any testing until they've had a bunch. And even after my 3rd miscarriage, I really had to beg for the kind of treatment that I wanted to help support my 4th pregnancy of that year, which turned out to be my son. But it wasn't until I had sort of dove deep on that topic. And my concern personally wasn't insulin resistance or elevated insulin levels. However, this particular topic actually illustrates the exact same point, that there are women that we perhaps could identify as having challenges with fertility and with miscarriage risk before they try and get pregnant. And we could actually improve their odds of carrying to term if we actually investigated a little bit sooner. So that's what we're going to focus on today. And this episode really is very relevant for women who have PCOS, who are preconception or pre-contemplating family planning. This episode is helpful for women who have struggled with weight management, perhaps sit above their ideal BMI or above their ideal body weight, or who have had investigation as to their blood sugar that has shown that there is a little bit of dysregulation there with blood sugar. And I'll explain what kind of testing you should have because you truthfully probably have not had that. And then this episode also is great for women who have had a previous gestational diabetes experience, previous preeclampsia, or previous miscarriage, because this deep dive on the concept of insulin resistance is actually a window into understanding all of those conditions and really should be offered to women who fall in all of those categories to make sure that we're actually trying to assess women before they've had multiple miscarriages or multiple failed fertility rounds or cycles or what have you. So insulin is a hormone that is typically, it's kind of a growth hormone. So it isn't growth hormone, but it is a growth hormone, meaning that it stimulates growth. It stimulates or causes glucose uptake into the cell. It's certainly a hormone I would say maybe 15 years ago none of my patients had heard of. And now with the concepts online of things with like fasting and discussing the relationship between hormones and metabolic health and weight management, I'd say more and more patients are familiar at the very least with what this hormone does. Insulin is released when we eat, and it's really released when we eat all food, not just carbohydrates. And it facilitates the uptake of both glucose and proteins or amino acids into the cell for the cell to basically be fed after you eat. Now, insulin can become dysregulated in patients, especially when they have been exposed to high levels of glucose or low levels of activity or some sort of imbalance in their metabolic health, whether that's overeating or under-exercising, or perhaps even a genetic tendency towards struggling with insulin, where insulin is effectively overproduced to do the same action that it would be produced at a lesser amount in a different patient. So I always try and use numbers when I'm explaining this to patients. And although for my medical friends that are listening, I recognize that these numbers literally don't make sense, but it helps patients understand the concept of insulin resistance and how it's essentially your body yelling at your food rather than whispering. So when I explain it to patients, I'll say, like, let's say we happen to eat a donut and that donut has 100 molecules of glucose in it. When a patient has, really good insulin sensitivity, they may release 100 units of insulin. Again, I'm recognizing that these numbers are made up. They make 100 molecules of insulin and the glucose is a scratch, right? The donut was 100, you made 100 insulin and everything was a scratch. When patients have insulin resistance or struggle with insulin regulation, when they eat that donut, they make 10,000 insulins to deal with that one donut. And what often ends up happening is that their fasting levels or even their daytime levels of insulin are higher than they need to be to deal with the food that the patient is eating on a regular basis. And so these high levels of insulin become problematic because insulin is not a benign hormone. It does other things. It's involved in appetite regulation. It can cause fatigue. It causes sodium retention, which can leave patients with higher than we would expect blood pressure. And this insulin resistance, when it goes on for a long time, eventually can lead to patients struggling with other problems with metabolic health and then eventually type 2 diabetes, where that insulin resistance and the chronic overproduction of insulin eventually leads patients to maybe struggle with insulin production later in their life. And they may require insulin in the future as a treatment for their diabetes. Now, this is important because in our younger female population, insulin is having an impact. And from a fertility perspective, it's kind of impacting things. I'm going to say twofold, but maybe it's actually threefold. So for women who have elevated insulin levels or who struggle with blood sugar regulation, they may have difficulty ovulating. So the actual act of producing and releasing an egg is dependent on many, many hormones, and those hormones have to go through a particular sequence over a 4-week window of time through the menstrual cycle. And when women have high levels of insulin, the insulin actually creates disruption in all of that signaling. And what it leads to is women not growing a dominant follicle and then not releasing that dominant follicle as an ovulated egg. And sometimes we can see this on ultrasound. And so for women with polycystic ovarian syndrome, if you have had an ultrasound where you have multiple little follicles, or we call them cysts when we see them on ultrasound, and none of them are particularly dominant, meaning there isn't one girl there that's been picked to grow above all of the rest, they all end up in sort of this paused growth phase where they all appear about the same size and none of them are ready to be ovulated. And that sort of process is actually driven by insulin, and these elevated levels of insulin will change your likelihood of ovulating. So even when we're talking from a fertility perspective, women may have started to notice that they're struggling with their insulin levels just by nature of whether or not their cycle comes regularly or whether or not they are showing signs of ovulation through the month. So sometimes even a patient who has not been diagnosed with PCOS, but maybe is struggling with elevated levels of insulin, may not ovulate consistently enough for them to be able to track their cycle or use ovulation predictor kits at home. And so they notice that there's something like hormonally being disrupted at the level of ovulation. And that's certainly going to impact their likelihood of falling pregnant because they're not releasing an egg consistently. So in these women, insulin is causing challenges with fertility at the level of ovulation, right? And so without ovulating, like I just said, our likelihood of falling pregnant is lower just because there isn't an egg being released each month. So those elevated levels of insulin are impacting mostly our sex hormones and gonadotropins, which are what are released from the brain in order to signal to the ovary to release an egg, and then also disrupting the sex hormones around the ovary as well. So women often have an overproduction of testosterone sort of as a consequence of having these elevated levels of insulin. But what I really wanted to focus on was the impact that insulin has on miscarriage risk, because I think that this is sort of an under-assessed area. Women who are not ovulating regularly will often land themselves in a fertility clinic. And what we do beautifully in fertility medicine is get embryos, whether that's to stimulate embryos with certain medications like letrozole, or whether that's to retrieve embryos from women that we've sort of overstimulated in order to extract those embryos for an IVF procedure. We laser focus on the ovulation aspect of fertility care, and we often don't address the underlying reasons maybe why that woman was struggling to ovulate in the first place, or don't have good conversations about her baseline health. And so a woman who is struggling to get pregnant, we remove an embryo, remove an egg, we create an embryo, and then we're effectively putting that embryo back into the same woman that walked in the door that was having a hard time. And we're not having that conversation with that woman about whether or not she needs to address any other areas of her health in order for her to be more successful at the fertility treatment that she's going through, or to help her better understand perhaps why we needed to use fertility treatment in the first place. So why I think insulin is so important to have a discussion on is, one, it's monumentally impactful when it comes to miscarriage risk, especially in that group of women that I kind of highlighted at the beginning of the episode. So even women who've previously been successful at having one child, but who had gestational diabetes, may struggle with insulin resistance and miscarriage in a second pregnancy, or women who struggle with weight management or who have been diagnosed with polycystic ovarian syndrome may struggle with insulin issues at the level of the miscarriage, not necessarily just at the level of ovulation. Or we push her through some kind of fertility care, we laser focus on the egg, and we forget that there's a whole woman around that we really need to cooperate in order to carry a pregnancy to term. The other reason I like to focus on insulin is because it's a relatively easy thing for us to assess, and we don't. So when women are being assessed for their general health and well-being, they're often having a fasting glucose tested, which is their blood sugar, not their insulin. And so quite often when I say to women, okay, I would like to test your insulin, she'll say, I've had that done. And then she'll point to her blood work and she points to her glucose or her hemoglobin A1C. Now, although those numbers are important, you likely are not frankly diabetic. And if you are, then you're being appropriately treated for that, likely. And that treatment you're getting is actually improving your outcomes when it comes to fertility. And so that's good. The problem is that the vast majority of women who are between the ages of like 25 and 35 who are looking to fall pregnant have normal levels of blood sugar, right? They're at that stage of insulin resistance where their body yells at the donut. So if we go back to my example, right? They eat the donut. They make them, many, many, many molecules of insulin to deal with that donut, but the donut goes away, right? Their blood sugar stays normal. It's their insulin levels that are not normal. Their insulin levels are elevated because their body is needing to overreact because of insulin resistance to the food that they're eating. And the insulin number is the number that we actually are more interested in. So we don't test for fasting insulin very often. And even when I point patients back to their family practitioner or endocrinologist to suggest that we test for insulin, it's often discounted as a test that's not particularly useful. I often have physicians say, well, we would know if you were diabetic because your blood sugar would be elevated, right? Or we don't need that number. It's not important and not helpful. Your blood sugar is fine. But the research on insulin when it comes to miscarriage is actually really profound, and it points to a general underdiagnosis of insulin resistance if we focus on fasting blood sugar or hemoglobin A1C by itself. Which that means is that the tests that women are having routinely on their physical exam to assess their blood sugar are not a deep enough dive into their insulin resistance to help us understand their miscarriage risk. And yet we're positioning it as if that's the gold standard for assessing blood sugar as it pertains to fertility and miscarriage. But the research is that it isn't. So there's been some great studies that have looked at the number of women that we miss if we just use a fasting glucose or just use a hemoglobin A1C versus if we put them through more comprehensive testing. So there was one study in particular that actually looked at the number of women that we catch if we put them through an actual 2-point glucose and insulin test to try and assess whether or not their blood sugar was irregular on like basic screening tests versus what happens if we put them through more comprehensive screening tests. So there was and so in this study, basically what they did is that they put some women through routine testing and saw who passed. And then that same group of women who had recurrent miscarriages and also who had gestational diabetes, so it's the exact group of women that I'm talking about, they then put them through more comprehensive testing to see who got flagged on both sets. And they actually found that 60% of the patients would have been missed through routine testing. So those women had elevated levels of insulin and glucose when they did more comprehensive testing versus if they did standard testing. This is a really recent article. It was just published in August of 2020. But it was specifically in women who had recurrent miscarriage. And what they found is if they did like more significant testing, which is not typically offered to women, they found that 60% of those women were missed as far as being screened and assessed for elevated insulin and impaired glucose regulation. Like 60% is a lot, right? And in medicine, we have a general tolerance for false positives and false negatives as far as like what we're willing to accept when we put patients through testing. And sometimes if a test will capture 90% or 95% of cases, then of course we're not going to offer a more expensive, more invasive, bigger option to everyone, because we're really only missing a very small percentage of the population if our screening test is capturing about 95% of women. But if the testing that we're putting women through is missing 60% of our women at risk, it certainly calls into question whether or not testing insulin, testing oral glucose tolerance, we call it, where you drink the drink and then they test you at an hour and 2 hours to see how well you deal with that drink, really should be called into standard practice, especially for the women that we're talking about in today's episode, who we probably already know just by talking to them are struggling with glucose management and struggling with insulin resistance. So this is why I'm passionate about this particular topic, because we're not doing a good enough job with basic public health screening to capture all of these women, and the evidence is really clear about that. Now, before I launch into why insulin is a problem, because I do want to spend time there, I want to just pause for a minute on this sort of concept of self-advocacy and education for women. Just to mention that, one of my goals for the last year or two have been to impact and reach more women as it pertains to their understanding of their own fertility and miscarriage risk. Because, as I just mentioned, we're really not offering things at a public health level that are capturing enough women into our risk profile and helping those women understand the things that they can do, which are really quite basic, to help support things like their insulin resistance as it pertains to their fertility and miscarriage risk. So when I wrote Carrying to Term, the goal there was to reach, thousands of couples, and we really have accomplished that and have helped people understand what their risk of miscarriage is, to help them be able to have those conversations with their practitioners. We get great emails and messages from readers all the time about the impact that the book has had on their fertility journey. And as a compendium to that, I've actually developed a course, a 4-week fast-tracked fertility course that is essentially a boot camp for women who are going through fertility care to help them start to develop a plan for themselves with better education and a better understanding of what the basics of fertility should look like. And that gives them the language and the confidence to be able to go back to whether it's their own naturopath or practitioner or fertility clinic, and advocate for the kind of testing that I really want them to have. We're launching the fast-tracked fertility course again in January 2021, so shortly after we release the episode of the podcast. You can actually sign up for the program even if you don't live locally to me. And this has been one of the other advantages to us moving to this group education program, is that we can start to work with patients that are outside of our jurisdiction, or work with women outside of our jurisdiction to help them be able to access care wherever they live. So if you're interested in that program, we are limiting the number of spaces that we will accept women into the class. And it does run for 4 weeks in January. There is a link in the show notes that you can access the page that gives you all of the information about what we're covering, the kind of support and benefit that you get from enrolling in the program. And we go through topics just like this on, from a treatment perspective, like how would a woman make shifts or changes so that she could support her own insulin if it was elevated. We review all of that in the course. And so I'm super excited to be able to bring that to, so many women and be able to share my story as far as my infertility journey, but also to be able to support women who need it, who are going through fertility care or who are just starting to think about their fertility and preconception health, but don't know where to start. And we all know how good Dr. Google is. My goal is to offer an awesome resource for women who are struggling and who want to feel more confident in their fertility journey. So the link for that is in the show notes of today's episode, Fast Tracked Fertility. So the reason that we find insulin such a problem, so let's go back for a second. We know it's a problem, right, in large subgroups of women. We know that we're under assessing for it. Even just that statistics in that one study should be enough to make us nauseous about how little we're picking up on this as part of a fertility assessment for women. But why is it actually a problem? So I noted earlier in the episode that part of the insulin issues is targeted around ovulation. And for some women who ovulate through their insulin resistance, meaning that they can continue to ovulate sort of past the problem of insulin resistance, it may make us less interested in their insulin resistance because they're ovulating. Like when we think about women with polycystic ovarian syndrome or women who are overweight or obese who are struggling with regular cycles, if you get a period or if you get a positive ovulation, we might congratulate that we've done all the work that needs to be done with this particular patient. But the work related to insulin is not done just when we ovulate, because the impact of having elevated insulin levels on maintaining a pregnancy is actually one of the areas that we should be focusing on. When insulin levels are elevated, it influences a couple of processes in the development of the placenta. And if we imagine the importance of the placenta, like it's the very sort of, life force blood connection, nutrition to the baby as they're growing. And the development of the placenta is a very important step in maintaining a healthy pregnancy, because placentas that don't form or develop well, certainly on like the macro scale, end up causing issues later on in pregnancy, right? For either, intrauterine growth restriction, or small for gestational age babies, or babies that cannot be supported or sustained by their placenta. But at the very micro level, when the placenta is compromised, we're seeing an increased risk of miscarriage in these patients. Now, for women with PCOS, this is hard to study, right? So as you can imagine, we can't, take an easy look inside what's going on when women are falling pregnant and what's happening at that micro level. We do know that women who have had elective pregnancy termination, who have had elevated insulin levels, that their placentas are not the same as women who had normal insulin levels. So when we compare those placentas of those terminated pregnancies, the women who had elevated insulin or who had polycystic ovarian syndrome, their placentas were smaller. They had less blood vessels than the women who had normal insulin. And so we can see that there is something metabolically happening at the level of the placenta in women who have PCOS or who have elevated levels of insulin. And studies have been done since then. Certainly we have a plethora of animal data, which I never love solely relying on. However, like I said, it's hard to stick our head in there and see what's going on. And even at the micro level, it's hard to assess placental growth and development. But in animal models, where we look at rat studies or look at mouse models, the placenta of mice or rats that are exposed to high levels of insulin, there's actually a directly toxic effect of the insulin on those placental cells. So they don't develop the way that they should. They actually decrease the amount of blood vessels that are formed. The cells themselves actually struggle to survive. And there's more what we call reactive oxygen species, or, at the basic level, inflammation happening in the placenta of those mice or rats that we're studying in sort of that same context. And we do see that in women with elevated insulin levels as well. We see higher levels of reactive oxygen species or inflammation in their placenta. We see less trophoblastic development. So those are the specific cells that are growing that are related to the blood connection, so that maternal fetal connection. We actually don't see a thriving connection in women who have elevated insulin levels. And interestingly, if we give, anti-diabetic medication to the rats or even to women with PCOS, we see a decrease in the inflammation or reactive oxygen species that are in their placenta. So they actually have less inflamed blood vessels. The way I describe it to my patients is that essentially women who have PCOS are at a high risk for cardiovascular inflammation. But when you're 30, it doesn't really matter, right? It doesn't show up as heart attacks in women who are 30. However, when we're looking at placental development, we're talking about new blood vessel development. And in women who have this vascular inflammation, reactive oxygen species, and inflammation, we're growing new blood vessels in that context or in that environment. And that's where it shows up. It's basically like having a cardiovascular disease of the placenta. That's really kind of the best way to describe it. So those elevated insulin levels have a really big impact on what's happening at that cellular level for the placenta. And so you can see, like, ovulation aside, the elevated insulin levels actually were having a big impact on how healthy that placenta is as it develops. And that is going to predict whether or not those women can maintain that pregnancy. And then even if they do maintain their pregnancy, they're having a higher risk pregnancy, because now the placenta, which is really like the engine of so much related to pregnancy. The placenta makes its own hormones. Like there's lots of things we need a healthy placenta for, is now being compromised, and that shows up in the risk of the pregnancy in general. And lastly, another area that insulin is having an impact on is actually reflected in another blood marker called homocysteine. So homocysteine is a what we call a residual cardiovascular risk factor, meaning that sometimes we're testing it in patients who have cardiovascular disease or who we're suspicious have cardiovascular disease, because it's typically made in that context. It's a biomarker that's made as it's made actually related to sort of the breakdown products of different amino acids. So as we get one amino acid moving into the other, methionine to cysteine, homocysteine is this like temporary intermediate biomarker that our body makes. So it's basically en route from like A to C. Homocysteine is B, and we temporarily make homocysteine on our way to making cysteine in our body. And this is a normal process that's happening all the time. Homocysteine levels we can measure in all people, in all humans. Everyone has some homocysteine. But we've typically looked at homocysteine as being a marker or a biomarker for cardiovascular disease. And it is also elevated in women who have elevated insulin. So insulin actually influences the production of homocysteine and raises the production of homocysteine in a way that we don't really want to have happen. And that elevated level actually causes problems when it comes to placental development and miscarriage. So we used to think homocysteine by itself was just this biomarker. So biomarker is like if we find it, it's telling us something. So finding elevated homocysteine was telling us that patients had cardiovascular disease, or were telling us that they have a B12 deficiency or a folate deficiency, both of which are required to lower homocysteine. However, that molecule homocysteine is not inert, meaning it does things in the body. And so having elevated levels of it is not just a flag for something else, which is typically how we've looked at it. We need to pay much more attention to those elevated levels because that molecule itself, homocysteine, is having a detrimental effect as it pertains to fertility, specifically for miscarriage, but also we see elevated levels of homocysteine in other negative pregnancy complications like neural tube defects or gestational diabetes or preeclampsia. We see elevated levels of homocysteine kind of across the board in all negative pregnancy outcomes. And so it certainly is something that we would want to pay attention to. So the interesting thing we see in vitro, which is looking at test tube data or cell data, is when we give homocysteine or homocysteine levels are elevated, that molecule itself is directly toxic to the placenta, but also causes myometrial contraction, which is the muscle cells of the uterus actually spasm and contract in the presence of high levels of homocysteine. So beyond it being just a biomarker for insulin resistance, that molecule itself actually needs to be low so that we don't have this sort of inflammatory toxic effect happening at the same time as us trying to develop healthy new cells at the level of the placenta. The other kind of amazing thing is that these levels of homocysteine in these women who are having a negative effect from it are not having astronomical levels that get flagged or bold on their lab work. So the difference between women who don't have PCOS, who don't have insulin resistance and have normal homocysteine, their levels may be somewhere in the sort of the 7 to 8 range, whereas women who have insulin resistance or who are struggling with insulin, whether they have polycystic ovarian syndrome or not, their levels are about 11 or 12. Now, statistically, that is a significant difference between those two. We can tell that that's not due to chance. That's due to their insulin resistance that's causing those numbers to be so different. However, the reference range for homocysteine's upper level to be flagged, frankly, on your blood work, which means it's bold and someone can point a finger at it and say, hey, there's a problem there. The level in Canada and in the US actually is 25 picomolars per liter. So these women with elevated insulin, with homocysteine levels that are toxic to the placenta, are still coming in below the 50th percentile of what we would find acceptable for this lab test. And that's because the typical population that we test homocysteine in is a group of obese type 2 diabetic men with cardiovascular disease. And that's where we develop the reference range. So by looking at those men, we found if they had a homocysteine level of 26, then they were having more significant cardiovascular risk. And so we created a level of 25, and below that is acceptable. But the difference between having a level of 7 and having a level of 12 is actually really remarkable for women on the impact that it has on their recurrent pregnancy loss, the impact that it has on the likelihood of them having gestational diabetes or future challenges in their pregnancy, all of which we're trying to avoid. So I can't emphasize enough that I think that lab test is particularly important, especially in women in this sort of gang that we're talking about here that is maybe struggling with insulin regulation and blood sugar and yet trying to fall pregnant. So now the big question is, well, what do we do? Right? So I think what I want your takeaway to be from today's episode partly is that there's lab tests that you need to have. And advocacy is one of my goals with the podcast. I want women to know what to look for in the lab work that they're asking for. I want them to know what to look for in a practitioner that they are working with, to know that they're willing to have, all of the lab tests done that would help us truly understand their risk without letting them go through multiple traumas, meaning pregnancy losses, before we start to be truly interested in what's going on with them. So that's part one. I want you to just know that those two tests need to be done, a fasting insulin and a homocysteine, especially if you're in this population of women that we have high suspicion that you're struggling with insulin resistance. Now, the treatment for insulin resistance is multifactorial, and part of it can be through dietary and lifestyle changes. Part of it can be through medication, and certainly there are some supplements that do decrease insulin resistance. And of course, I want you to speak to a healthcare professional about that. Of course, I want you to have a tailored plan. But mostly I want you to know that there are options. And for the most part, the medication options that are offered for women like metformin to help them get pregnant, women are often shocked that they're being offered an anti-diabetic medication in order to help them fall pregnant, or maybe, almost offended that that's what's being offered to them as a solution when they are very, very obviously not diabetic. But the reason is because it lowers that high level of insulin. And even if we give women metformin, their placenta is less inflamed. Their placenta has less reactive oxygen species, and they are more likely to carry to term, especially if insulin resistance was part of what we thought was related to some of their concerns. So I want you to just have that on your radar, that if, you get offered solutions that don't totally feel appropriate, that they're likely targeting that particular biomarker, meaning insulin, and also homocysteine, to try and help you achieve what your goals are, which is to not just fall pregnant, but stay pregnant and then carry a healthy pregnancy to term. I'm sure you can tell after listening to this episode that this is something I've spent a ton of time on, and it's something I'm incredibly passionate about, which is really what led me to create the Fast Track Fertility course. Because, if you think when I sit down with a woman one-on-one, the amount of information that there is for us to cover is really quite profound, and the amount of discussion around blood work that she may or may not need, or solutions that she may or may not need as it pertains to her particular scenario. I mean, we can talk about food and nutrition and supplementation and lab tests and medication options. It's hundreds and thousands of hours of work on my end to try and communicate and distill down in a really short period of time for women. So my goal with creating the course was to give women freer access to information about their fertility and to help them get the tools to start to develop a plan for themselves to feel a lot more confident about it. If I've learned anything about working with women who are on this preconception journey, it's that they are hungry for information. I've never met a more motivated woman than a woman who's trying to fall pregnant, and she will consume thousands and thousands of Google pages and blog articles and podcasts, just like this one, to try and help her understand what's real and what she should be doing. And often when I sit down with that woman, she's overwhelmed and confused. She's been told that there's hundreds of foods she should avoid and 10,000 foods she should include. She doesn't know if she should exercise or not. Like, it's quite a confusing time for her. And so my goal with the course is to create a lot of clarity, to present all of the solutions that are available for women and help them construct a plan for themselves based on this really solid foundation in education on integrative fertility. I'm really excited to offer that course, and we're going to be doing it more in 2021. That first offering opens for our first class on January 15th, and enrollment is open now. If this even remotely piques your interest, I would go back to the show notes and read through what we're doing with our group of women that sign up in January. It's a huge amount of support and a huge amount of time that you get during the course, and we will move you from that overwhelmed, not sure what your next step is, to understanding exactly how to take charge of your own fertility journey. This has been something I've loved doing over my 15-year career. It's one of my favorite things to get a call to know that we've helped a couple get a positive pregnancy test. And I'm excited to be able to expand our reach and work with a wider group of women and women who don't live locally to the office, or maybe we don't have the option of working with one-on-one. So go back into the show notes and click the link there so that you can see that course. The enrollment is open right now, and we totally expect to sell out. I hope you enjoyed that episode of Women's Health Unplugged. It's my absolute passion to bring women quality and science-informed information about their health so that they can make empowered, good decisions about their health care. I'd like to invite you to join me in my Facebook community, Women's Health Unplugged. There we share live videos, blog posts, and behind-the-scenes information about the podcast, where you can connect with me and other women who are interested in their health care. You can find us at facebook.com/groups/WH Unplugged. We'll see you there.